Hi all, I'm Chung Brewer. Today I want to talk about 3 ways to make your own cognition tasks, plus a bonus way. And there are a number of reasons why you might want to make your own cognition tasks. Maybe the patient just isn't vibing with wanting to do a worksheet, or you come in and you realize that it's not going to be appropriate for the patient, whatever you prepared. No matter what, here are 3 things and a bonus thing that you can do. Number 1, refer to their assessment. Areas of weakness in that assessment can point to cognition tasks. So you could ask yourself, what ways can this area of weakness show up in their daily life as their daily life is right now? For example, how could their memory impairment affect their day at the SNF? From meals to therapies to socializing or walking around their room. Make your best educated guess and try it out. Maybe they're really forgetful and they also need help transferring, so create a task to help them remember. Use spaced retrieval so they can remember whatever transferring technique they need. Number 2, look around their room. Their environment can give you clues on what they already interact with, and you may be able to help them interact with those things more readily or easily. This kind of thing of looking around their room can be especially helpful when you come in with some handy worksheets and then you realize that it's just not going to work out. Maybe they just aren't vibing with how the patient's feeling today, or they're just inappropriate. It happens. Here's how to think on your toes. Ask yourself, what are they already using in their daily life or used to use but can't anymore? For example, they have an attention impairment and it makes it really hard for them to read, but they love their magazines. So you could take whatever magazine is around, or you could look at an e-magazine online. They have them in the library apps a lot, and add in attention strategies for reading, like softly reading out loud, scanning along with their fingers, or using a piece of paper to cover up the words underneath. Number 3, know their schedule. Add in things they used to do but no longer do. Know what they do from the time they wake up to the time they fall asleep. Also know how much help they're getting with tasks before their injury and after their injury. Any difference may point to an area that you can support them in. For example, let's say your patient, their independence is really important to them, but after their stroke, they have a ton of new meds and it really would be safer for someone else to manage that for them. You can still work on medication management together and start with knowing what their new meds are. You could print out their medication list and then transfer it to another piece of paper so it's easier to scan. And then you could also literally be there as they physically sort out their weekly pills into a pill box using certain strategies, have a certain routine. A bonus way to make your own cognition tasks is just ask the patient what they want to do. That's person-centered care, baby. Sometimes you'll ask what they want to do. They might not know right off the bat, and that's okay. Rehab services, especially when they get started, can be really overwhelming. But just keep checking in. For example, maybe they love golfing. We typically don't go out on the course with them, but it's something they still care about. If they could physically go back on the course, but they have a hard time keeping track of their score, encourage them to write it down on a notepad or a notes app, and then help them set a routine that immediately after every stroke, they write down a note.